Welcome to Halteres Presents, a brand-agnostic interview podcast that seeks to objectively highlight the happenings within the world of diagnostics. And now, your hosts, Rich Thayer and Mickey Urdea.
Hello, and welcome to Halteres Presents. This is Rich Thayer, Managing Partner of Halteres Associates.
And this is Mickey Urdea, the founding partner at Halteres Associates. And today we're going to interview Dr. Niels van der Lelie, who's the Chief Scientific Officer and co-founder of Gusto Global. We had a wonderful interview with Niels, and we talked specifically about the human microbiome and the many insights that he and his team have come up with over the course of their work. I think that they've made a major advancement here in understanding that it's the function of the organisms and not which organisms themselves are important.
And now, our interview with Dr. van der Lelie.
Well, Niels, thank you very much for joining us. We're so happy to have you here today.
Well, it's a pleasure to be on your podcast.
For our listeners that are not familiar with your career, could you please tell us about your background and how you moved from plant microbe interactions to human microbe interactions?
So I started my career in the Netherlands. So I'm originally from the north of the Netherlands, Groningen, with a very strong dairy-related industry. So I did my studies on lactic acid bacteria, then moved to a small startup at the time. Now it's a very big company in France called Transgene. And again, work on lactic acid bacteria. But then I wanted to be a little bit closer to my family and ended up in Belgium. And I started working at the Belgium Nuclear Research Center, not on nuclear programs, but actually on programs that were important for cleaning up contaminated environments. And very soon we started to realize that some of these sites were so big that you cannot do that with traditional engineering methods. So instead of using dug up and pump and treat, we started looking at the use of microorganisms to immobilize, for instance, heavy metals, and the use of bacteria to degrade organic contaminants. And then instead of using, let's say, the typical engineering approaches, we started using plants like poplar trees to address and pump up the contaminated groundwater. We then started to realize that, in fact, there are a lot of bacterial interactions with plants, and that was known. But what was really new at the time was that actually bacteria are living inside plants. And it was actually quite funny when I was talking about this, for instance, at meetings, and sometimes these were lunch meetings. Then people would have their salad, and I would suddenly tell them, "Oh, by the way, do you realize that you have now about 1 million bacteria in your fork of salad that you're now putting in your mouth?" And I don't think that people that were vegetarian became again meat eaters, but definitely a lot of people I've seen that suddenly stopped eating their salad, looked at it, and decided to move on to the main course. So these bacteria were very interesting because they were complementing the metabolic properties of their host plants. And we actually also did work where we introduced new genes in these bacteria so that they got a broader spectrum of being able to degrade, for instance, organic pollutants. And all of this work caught the attention of the US Department of Energy. We started a collaboration out of Belgium with Brookhaven National Lab that resulted in me and my wife moving to Brookhaven National Lab first for a sabbatical, but then we were permanently hired and we stayed there until 2011. In 2011, we were actively recruited by RTI International, which is a non-for-profit research organization in North Carolina in the Research Triangle Park. And there we created a new center that focused on microbe-host interactions. So not only microbes and plants, but also microbes and humans, and for all kinds of applications, for human health, for ethnobotany. So for instance, what is the role of bacteria and fungi in medicinal plants, the production of secondary metabolites, and then very big, how can we improve agriculture as a way to get away from chemicals, chemical pesticides, and so on. So really agricultural biosolutions. That work caught the attention of a company called FMC Corporation, and there was a transfer then of our assets to FMC that happened in 2013. And so I worked then for 3 years for FMC Corporation, which was really very interesting to work in such a big company. And then in 2016, FMC wanted us to move to Denmark. It was a great opportunity, but unfortunately, it did not fit well with our family situation, having 2 daughters still in school and at the university. So we decided to decline it. And since we had non-competes, we had to move into a different field of research that could not be agriculture, and then decided to move into human health. And the reason that we were doing this was that many key functional interactions between bacteria and plants and bacteria and humans are very similar. So for instance, in both instances, microorganisms help to make nutrients more available. In both instances, they help to induce the immune system and defense systems against pathogens, helping to protect the host, for instance, from opportunistic pathogens in your gut, or same for plants. And overall, what we also knew was that if you have a disturbed microbiome, it makes the host more sensitive to diseases. So basically what we did was we took the lessons that we had learned from our research on plant microbe interactions and translated it in a new platform to look at the interactions between the human host and its beneficial bacteria, especially the bacteria residing in the human gut.
Fascinating background that you have. Thank you.
So once we left FMC, we created this company, Gusto Global. And the focus of Gusto Global was on trying to understand the interaction between the gut microbiome and the human host, and how these microorganisms play a key role in making the host more resilient to certain diseases, but also the role that these microbes play when the microbiome is dysbiotic in actually triggering disease. And you can think of many different applications. You can think of, for instance, the role of the microbiome in people that are suffering from IBD, like Crohn's disease or ulcerative colitis. But you can also think of the role of the microbiome in how people react to certain medical treatments. Especially an example that comes to mind is how people react to immune checkpoint inhibitor treatments, where there are lots of studies that show, depending on your microbiome, a treatment will be successful or not. So that really was something that we were interested in and that we wanted to develop for Gusto. Now, when we created the company, we did not have a lot of funding. And therefore, what we decided to do was first to develop a bioinformatics platform that became the best in class to look at microbial interactions between the microorganisms and also with the host. And we were very lucky that in addition to myself and my wife, Safieta Gavi, who's also a successful scientist, that we were able to pair with Chris Henry from Brookhaven National Lab as one of the co-founders from Gusto. And Chris was really instrumental in developing the modeling platform for Gusto Global. So we ended up in a unique situation where on one hand, we had 2 scientists, my wife and myself, that really understood how microorganisms were interacting together and with each other and with the host. And then on the other hand, Chris Henry, who had all the tools in the bioinformatics to put all of this together in an addressable platform. And that really caught the attention of the pharmaceutical industry. And we then were able to validate this platform with a pharma partner.
So what were some of the most striking observations you had concerning the gut microbiome and human host?
So at the time when we started Gusto, you would see a lot of papers appearing in the scientific literature around the importance of the gut microbiome. But what was interesting was that most of these papers were or nearly all papers, I would say, were focusing on the link between specific microorganisms and diseases. And yes, there are certain cases where it's extremely clear. If you have an infection with Clostridium difficile, yes, you have a C. diff infection. But then in the case of IBD, yes, people saw that certain microorganisms were more prevalent in people suffering from IBD, but it was not always clear. And there were quite some contradictions between the different studies. And when we started to analyze publicly available data sets from people with IBD and compare that with healthy individuals, we started to notice, yes, you have all these differences in gut microbiome compositions, but what is common is that you have in a gut microbiome that is causing a disease. It's not so much about the strains that are present or missing, but it's much more around functional dysbiosis. So, for instance, in a healthy gut microbiome, you have a rich diversity of bacteria that produce short-chain fatty acids like butyrate or propionate. In the case of the diseased or dysbiotic microbiome, you start to see that these functions are either missing or underrepresented, or that different pathways are being used to make the same kind of metabolites. So we really started to understand that species composition is one thing, but more importantly, it's the production of key metabolites that really drive the interaction between the gut microbiome and the individual, whether that is promoting whether or not you have a healthy situation or not. And you can start thinking of many different metabolites. You can think of metabolites that improve gut lining, like the tight junctions between the cells so that you don't get a leaky gut. You can start thinking of butyrate to feed and recruit Treg cells that help with anti-inflammatory properties. You can start thinking of the conversion of bile salts into secondary bile acids. So all these kind of functions are critical, and we noticed that there were these differences in these functions when you were comparing healthy individuals and people that were suffering from certain diseases. And that was really the driver of a lot of work that we subsequently did at Gusto.
This is one of the major reasons we wanted to have you on the podcast, Niels. This is a remarkable insight, I think. There's the famous saying by Ernest Rutherford that all of science is either physics or stamp collecting. And it just seems as though so much of microbiome research to date has been stamp collecting. And people are confused when they find different stamps in different people. And now you actually have a rationale for that, which is remarkable. I think it's just a phenomenal thing. Do you think that should change the way people do microbiome research now? And how are you approaching it that's quite different from what other people have been doing to date?
Going a step further, once you obtained these insights concerning the gut microbiome, were you able to use them for diagnostic purposes?
Basically, we have two different programs there. But let's first talk about the diagnostics, because I know that your audience is really interested in that part of the work that we are doing.
Absolutely.
So once we had these insights, we started to look whether or not you can use this as biomarkers. And we have currently a program with Brookhaven Women's Hospital where we are looking at ways to understand how patients are, how their, let's say, IBD and then especially Crohn's disease is developing. And we look at a combination of, on one hand, bacteria that are there and also certain fungi, and then on the other hand, the functionalities. And what we noticed, for instance, is that people that suffer from, let's say, Crohn's disease have higher prevalence of certain opportunistic pathogenic bacteria. That's well known. So if you start to see that, and even if these patients that are taking medication are feeling well, because the medication is basically knocking out the immune response of these patients, so they don't have the inflammatory feeling, you still know that these patients have not really been cured from the disease, and that the underlying cause is still there. So that's one of the things that we are looking at. So microbial biomarkers to see whether a person is really in remission or if it's just a matter of hiding the symptoms and the person feeling in remission. Then we look at the functional biomarkers. Do we see differences there? And the answer is yes. We clearly see differences in functional biomarkers. And again, it is linked much more to disease activity rather than, okay, do you have a disease or not? So I think that is the next paradigm shift. It's not just about, well, you're diagnosed with a disease, but it's going to be how severe is the disease and how significant is the underlying dysbiosis of your gut microbiome. And do you have a microbiome that is resilient, or do you have a microbiome that is susceptible to rapid perturbations that can result in disease flares? So that's the kind of work we are doing in the diagnostics.
That's fascinating. Listening to this discussion, it reminds me of some of the dialogue surrounding pharmacogenomics and the use of P450 several years ago, and whether or not it really was a useful or appropriate tool for drug selection administration. What are your thoughts here?
Absolutely. So, for instance, one of the studies that we were involved in, so the let's say preferred prescription drug for IBD patients when they are suffering from a flare, when they suffer from pain, is acetaminophen. So by looking at the combination of the metabolome of Crohn's disease patients that were having a flare and were taking pain medication, and then the microbiome, we could precisely link which microorganisms were actually involved in the conversion of acetaminophen in the gut into different compounds, especially sulfonated compounds. So it is absolutely, absolutely relevant. And I think there are clear cases where there have been statements made that certain people, have certain drugs don't function well in certain people, and it's not known why, especially if these are orally taken drugs. And the microbiome and the metabolic potential of the microbiome might hold some very key answers there.
There have been several studies published concerning the association of bacteria and fungi with cancer, some which have been pretty controversial. What are your thoughts about where this subfield in microbiome studies is going? For instance, will we see microbiome tests for early cancer detection or therapy monitoring?
One of the other fascinating microbiomes that people have started looking at is in the relation with cancer. And so on one hand, the presence of the gut microbiome, the composition of the gut microbiome will have an effect how certain therapies are working. But then in addition, and although there is controversy around it, it is absolutely clear that a lot of solid tumors are colonized by microorganisms. And there are cases now where the outcome of certain chemotherapy treatments really depend on the microorganisms that are sitting in these tumors. Because in some cases, when you apply these drugs intravenously, they will arrive at the tumor, but then the microorganisms have actually the metabolic potential to break down these drugs. So two things are happening. One, the drug is not working. And two, the microorganisms are like, oh, this is great, extra food. So I think it's very important, not only for diagnostics, and we can discuss that also, but also for the outcome of treatments in cancer patients. When you have tumors and you do tumor biopsies, to not only look at, okay, what are the typical mutations that you find in these tumors, like triple negative breast cancer as an example, but then also look at the microorganisms that are colonizing these tumors and what kind of metabolic capabilities they have and how that can affect the treatment outcomes.
That's fascinating.
There's been a lot of controversy about the correlation between organisms and tumors. And been some recent papers where people say they don't believe this. What is your opinion and how do you arrive at that?
My opinion is that definitely there is a correlation between the presence of bacteria, fungi, and tumors. And the reason I say this is that um, if you take solid tumors and you do certain stainings on these tumors that are specific for microorganisms, like for instance fluorescent in situ hybridization with probes that target the 16S RNA gene, which is something very specific for bacteria. You won't find that in eukaryotic cells like the human cells. You clearly see signals there, and not a little bit. You can see very, very strong signals that really show that these microorganisms are there and are present. The controversy comes from whether or not you can now use the microbial signal coming from the microorganisms that are present in these tumors and that are being attacked by the immune system. And therefore, these microbes will break down and will release DNA in the bloodstream. Whether you can use that as a tool to do early detection of tumors. That is really where the controversy is. I don't think the controversy is about whether or not there is a tumor microbiome. The question is really, is the signal strong enough to be able to detect it? And we have actually developed diagnostics to look at that. And in some diseases, we think they're actually certain kind of cancer, they seem to be quite successful. The problem is, however, that the signal is very, very weak. Let's be clear there. And very often, the signal is caused by bacteria that will colonize the tumor that are somehow opportunistic pathogenic bacteria. And then you start to think of bacteria like E. coli, Streptococcus, Staphylococcus, etc. Now, the problem is that many of these bacteria are also present on, for instance, the skin. So when you take a blood sample, you have a risk of contamination. It actually turned out the skin was not the largest source of contamination of DNA in blood. It actually turned out that the DNA extraction kits that have been developed to isolate DNA, for instance, from blood samples, contain very small DNA fragments. So during the production, everything is done in a way to sterilize these materials. But that's done, for instance, by UV radiation, and which is very similar to what happens in the body. You basically kill these cells, you break them open, and you break the DNA. So in these DNA isolation kits, there are lots of small DNA fragments, and they actually hide the real signal coming from the microorganism in the tumor. So I think it is a field that is open for diagnostics, but it requires technical innovation and also better bioinformatics tools to remove the noise from the real signal. So that is one thing. But then there's one area where I really think that the microbiome can be a very important diagnostics tool, and that is in colorectal cancer. So in addition, so what happens now is, let's say you have a stool test that looks for the presence of signals that are indicative for colorectal cancer. What are these tests based on? They're based on the presence of human DNA. They're based on the presence in the human DNA of certain mutations, some genes that are being silenced, some genes that look to be activated. And then, of course, also very importantly, the classical presence of blood in stool. So this is all combined. But there's still improvement to be made with these tests. And that can be done by also including bacterial signals, because these tumors often are caused by the presence of certain bacteria. So it's known that Fusobacterium nucleatum, subspecies nucleatum, is a driver, for instance, of colorectal cancer. There's a clear correlation there. Turns out, however, that's not always clear, and if it's the case or not. And then it's became clear that within this subspecies, there is a further differentiation simply based on the presence or absence of a specific pathway that either creates a product that is mutagenic or if it's present and if it's absent, it doesn't create that problem, that product, that is causing this increased risk for tumor development. So we have developed tools to look at that at a very low cost without having to do metagenome sequencing. We developed tools to be able to look at the composition of these microbiomes with much better resolution than 16S, and also include for key organisms functional genes that can then further provide insights whether or not a person is at risk for developing these tumors or not. And I think by including this microbial signal, it's not going to help you by later stage detection of colorectal cancer, but it will create, I think, a better profile to specify whether you're at risk or not to develop colorectal cancer, and for instance, whether or not you require more frequent screening than what is currently recommended.
Would it alter the way in which colorectal cancer is treated?
It could be, but it's very complicated, because what are you going to do then? Are you going to give these people antibiotics with all the consequences? So that's not going to be easy. I would see two possibilities to treat people like this. One would be to develop phage therapies that could specifically go after bacteria that cause these, increase the risk for developing colorectal cancer, like certain strains of E. coli, certain strains of Fusobacterium, etc. So that is one approach. And secondly, would be to look at the microbiome of these people and see whether there is a dysfunction going on, where with, let's say, a specialized probiotic intervention, you should now be able to maybe not completely remove these harmful bacteria, but at least control them and make sure that they don't become a major component of the gut microbiome.
It's so amazing you just brought this up, Niels, because have you ever read this book? The Living Medicine, it's called.
Okay.
About phage therapies that were derived originally in Russia, Soviet
I know.
Union later. It's an amazing book. I knew some of it, but it was just incredible how effective phage therapy has been.
Yeah, it is. And it actually is coming back now. There are several companies working on doing great work, also here in North Carolina. And it's really a way to address multi-drug resistant bacteria.
Yeah.
And in the case of, so why would this be important? So for instance, in the case of ulcerative colitis, there is a much higher risk for those patients to develop colorectal cancer as a comorbidity. And the reason is that these patients often have higher levels of opportunistic pathogenic bacteria like E. coli, like Fusobacterium nucleatum. And so on one hand, it drives ulcerative colitis, and it can be used as an indicator strain there, but it also can drive the comorbidities. So it's really important, again, as an example here, to include the microbial understanding for these patients. Not just about, hey, you have ulcerative colitis, but really as part of disease monitoring and different progressions that a patient is making.
Right.
Niels, this has been a fascinating discussion. Shifting gears for a moment, besides diagnostics, are you also planning on using these insights for interventions to improve gut health?
So actually, yes. So as an example, our programs were really focused on IBD. And in collaboration with Balfour Sartor at UNC in Chapel Hill, we started to develop and then validate various live biotherapeutic products to address the underlying dysbiosis of the gut microbiome in IBD patients. And the focus of the work was on using a mouse model. These are so-called IL-10 minus mice And it's a very well validated model for IBD, especially ulcerative colitis, where these mice rapidly develop colitis, especially if you introduce a human stool. And what you start to see is in these mice that the same kind of reactions, you get dysbiosis of the microbiome, you see the increase in these opportunistic pathogenic bacteria like Fusobacterium species, like the typical Enterobacteriaceae like E. coli, Salmonella, etc., and also pathogenic Clostridia. And what we did different from what others were doing at the time was not take a bunch of Clostridium species that people were focusing on because of their capacity to produce butyrates, but to really look at what are the key functionalities, as I mentioned before, that were missing in these dysbiotic microbiomes, and then take bacteria that were really representing these different functionalities. So gram-negative bacteria like Bacteroides, an Akkermansia, certain Clostridium species, etc., and then build consortia of 10 to 17 bacteria that, on one hand, provided all these missing functionalities, preferably with duplication, so not one bacterium having this one function, but several bacteria being able to provide these missing functionalities, just in case if you introduce this bacteria, one is not getting engrafted and established. And then in addition, we also made sure that these bacteria were supporting each other. So if you look at bacteria, there is hardly any bacterium that will make everything it needs to grow successfully. It always will depend somehow on another bacterium, like it cannot make certain amino acids, it cannot make certain vitamins, it cannot make certain cofactors, etc. So what we did was to make sure that these bacteria were able to form a network where all these bacteria were supporting each other, that all the, what I would call metabolic currencies were present, so that each strain had at least one or two other bacteria that would support it. And then we would make sure that the different key functionalities were also present. And we published this work in 2021 in Nature Communications. And what we were able to show was not only do these communities get established, both in mice where there were no competing microorganisms, but also in mice where there was a very well-established humanized microbiome that was causing ulcerative colitis in these mice, experimental colitis. But then all the key functionalities were basically restored once you get the establishment of this network of beneficial bacteria. So we noticed, for instance, a very sharp drop in the opportunistic pathogens. We saw the establishment of the bacteria that we introduced, but also other beneficial bacteria that were still there but were underrepresented. They now had an ideal environment to start to flourish, so their numbers went up. We saw increase in the production of these short-chain fatty acids, like, for instance, butyrate. We saw an increase in the synthesis of indole-like compounds important for triggering healing of the leaky guts and the tight junctions. And then very, very importantly, we noticed a very significant decrease in pro-inflammatory cytokines like IL 12 P40 went down significantly, interferon gamma went down significantly, TNF alpha went down significantly, and that's exactly what you want to see. The levels don't go down completely. It's also not that these mice now have a nuked immune system. What you get when you use these drugs like Humira or Remicade that specifically take out key cytokines, but then have all these secondary side effects like increased of serious life-threatening infections, increased risk for certain types of cancers. No, we didn't see that. And then also what we noticed when you introduce these bacterial consortia is an increase in beneficial anti-inflammatory cytokines, like for instance IL-10. And then last but not least, also we got again normal bile acid profiles in these mice once you introduce the beneficial consortia. So I strongly believe in LBPs, but I also strongly believe then that you need very good diagnostic tools. Again, not just looking at the typical medical parameters, but also to look at what is happening in the gut microbiome, the bacteria that are there, the functions that are being restored, and if you have the possibility, link it to metabolic profiles to see that it's really from a functional point of view restoring these dysbiotic gut microbiomes. Unfortunately, we never had the funding to move this from a research phase into the clinical phase. This was in part due to COVID. So by the time we were ready to do this, COVID hit, and that's seriously affected the industry, unfortunately.
It's microbial metabolomics that you've created.
Well, I contributed to it. I would not say I created it, but definitely contributed to it. When we are developing these products to intervene with the microbiome that is dysbiotic, I mean, people often think of probiotics. Well, probiotics are just a few bacteria, and I would be happy to tell a bit more about it because we also have a probiotic program. But what we are doing is something that is called live biotherapeutic products. So it's not just providing some health benefits like probiotics, it's really therapeutic. And actually, when we are testing these so-called live biotherapeutic products, or LBPs as we refer to, we actually use two different protocols. One protocol is preventive. So what we do is we introduce in a mouse model these bacteria, this LBP. It gets established, and then we try to see what happens when we challenge it with an opportunistic pathogen. And we see then that this opportunistic pathogen has a horrible time to get established, which is great. But then also, which is more important, is what happens if a person has already the disease? If a person has already these opportunistic pathogenic bacteria that are now well established in the microbiome of a patient, then what we do is use a so-called therapeutic protocol where you really try to heal the person, where you really try to reverse the pro-inflammatory microbiome. And that is something we aim for with these live biotherapeutic products, not just preventive, but really to become therapeutic.
How is this new probiotic different from competing probiotics that go beyond lactic acid bacteria? Is the mechanism one where you're modifying the microbial community, or is the host involved? Is it the metabolism of both combined? How should we think about this?
So the microbial community is not a standalone thing. So let's say as a person, you are suffering from IBD. You will have an inflammation, and as a result of that inflammation, the immune system is going to release all kinds of compounds to try to control, let's say, the bacterial dysbiosis. Now, unfortunately, many of the opportunistic pathogenic bacteria are adapted to these kind of compounds. So, for instance, the host will release like fecal calprotectin. The host will try to interfere with iron metabolism. There will be the release of reactive oxygen species that a lot of beneficial bacteria don't like. So what you start to see with these kind of diseases is a self-enforcing circle where the bacteria cause inflammation, the host tries to repair it or counteract it, is releasing compounds that further will, in certain cases, not always, create a more pro-inflammatory environment where these pro-inflammatory bacteria are thriving again. So that is why it's so important to intervene in this circle. And there are two ways of doing this. On one hand, with medication, where you interfere or intervene with the human host, and those are these anti-inflammatory drugs. And then on the other hand, the interference at the level of the microbiome, where you try to suppress these pro-inflammatory bacteria. And so when we create these live biotherapeutic products, we do two things. On one hand, we actually try to restore the missing functions. But on the other hand, we make sure that we have bacteria that are very competitive with these opportunistic pathogens. And we do that via several mechanisms. One mechanism is, for instance, to compete with iron. So the bacteria that we use are either able to produce their own siderophores, which are molecules produced by bacteria and microorganisms to trap iron. But some of these bacteria are also able to take up the siderophores produced by these opportunistic pathogenic bacteria. So basically use what they produce against them. So, hey, great, you are feeding me now. Then secondly, these bacteria that we use, several of them are capable of producing natural antimicrobial compounds that are now targeting these opportunistic pathogenic bacteria. And that's happening all the time in your gut, but we just make sure that we have more bacteria that do that. And we also make sure that these compounds don't target the good bacteria. And then last but not least, because they now have a competitive advantage, they're just going to displace the bad guys. And you start to see that the numbers go down. And as a result of that, the human host is going to create less of a pro-inflammatory environment. So you're basically reversing now the cycle. And that's what we are trying to do.
That's great.
You know, we've also heard that your company is working on a new probiotic. How is your approach different or different from what you've described already for the LBPs?
So when we started our program on probiotics, it was actually driven by observations we made with our LBP program. So in any model that we were using, we always noticed that there were a couple of bacterial species that became dominant and really formed the foundation for the other beneficial strains to hook onto. And we used that information to say this is how an ecologically relevant probiotic should look like. And I don't want to talk now too much about the composition of our probiotic. But what was really important as a next step was to say, how do we use this probiotic to address the critical flaws in the current probiotics? And if you do this, if you look at the current probiotics, if you go to the supermarket, you see that most, not all of them, but most of them are based on lactic acid bacteria. And these are the same lactic acid bacteria that are also used in food fermentation, etc. The same kind of lactic acid bacteria that you can find in probiotic yogurts, etc. So it's a very narrow approach to a very complex ecosystem. Secondly, these bacteria, as I said before, they come from the food industry very often. So they're absolutely not adapted to the human host. So they will show very poor engraftment. So they will really fail to colonize the critical ecological niches in the core microbiome. And as a result of that, they can't be used by other beneficial bacteria to really hook onto. Then many of the current probiotics have a problem that there is vulnerability to oxygen. So people have tried to make other probiotics using other bacteria coming from the gut microbiome, but these bacteria are very sensitive to oxygen. So that is also something that we have been working on to keep these strict anaerobic bacteria alive. So it's not only a matter to produce them anaerobically, but also to make sure when you formulate them. It's done under anaerobic conditions, but also with compounds that, if oxygen becomes present, they strip away the oxygen. And last but not least, to make sure that your packaging is such that oxygen does not enter and does not kill these strict anaerobic bacteria. So we wanted to make sure that our probiotics are based on bacteria that get established and don't have just a transient effect, as is the case now with most of the probiotics. And so these 3 strain probiotics that we are currently working on are based on beneficial commensal bacteria that are naturally found in healthy human guts, so not the generic lactic acid bacteria. They do not work on just one thing. They really provide multi-system support. So they improve metabolic health because they are producing key functions like, for instance, butyrate and also propionates. They work on gut barrier integrity, for instance, via the synthesis of these indole compounds. They affect, via other metabolites that they can produce, brain function. And then also have immune responses that are anti-inflammatory through synergistic interactions with, for instance, Treg cells, etc. Then there is a whole craze about weight loss, Ozempic, etc. And it turned out that the probiotic formulation that we developed already several years ago actually contains a bacterium that has the capability of inducing GLP-1 and GLP-2. So this is important for metabolic health of the host. So, for instance, to lower insulin resistance. So things like that.
That's pretty amazing.
Really, the probiotics that we are developing deliver comprehensive solutions through complementary strains with synergistic modes of action. I think that is really the key thing. So first of all, like for the LBPs, we made sure that these 3 strains are working together. We know this because of modeling. We know that these strains complement each other metabolic needs. We also see that these strains become the dominant strains when we introduce an LBP. And then they really cover a very broad range of key functionalities that you want to see reintroduced, reestablished in your microbiome. So I mentioned already metabolic balance. So had the production of short-chain fatty acids, bile acids, and also pathogen controls. All these 3 things, these 3 bacteria can do. I mentioned the importance of gut barrier. So one of the strains produces metabolites that really is key in triggering the natural process of gut barrier repair. It helps to fix the leaky gut. It reduces systemic inflammation, and by doing this restores intestinal integrity. We spoke briefly about the current probiotics, the big hype being Ozempic-like effects. So yes, these bacteria do hormone stimulation, and we have the data around this. So not only do these bacteria, at least one of them, activate GLP-1 synthesis, but also importantly, and it's part of this natural process that you don't see when you take a drug like Ozempic, it also will stimulate the synthesis of GLP-2 and then also of a factor called FGF21. And this is all important for metabolic optimization by the human host. And then last but not least, because of these compounds, it also shows anti-aging benefits. So for instance, GLP-2 is very important for mitochondrial health, which is a key thing in aging. And also some of these bacteria produce metabolites that actually help to communicate between the gut and the brain. And this is really where the expression, a gut feeling, comes from. It's these kind of metabolites produced by bacteria that will have an effect on your brain health, especially your mood, feeling happy. So in a way, we really feel that what we are developing is the perfect healthy aging probiotic.
Have you or has anyone else attempted to use something along this probiotic line in, let's say, mouse models, looking at obese versus non-obese mice? Some of the early successes in the whole microbiome field were taking the contents of the gut of a obese mouse and moving it to a non-obese mouse and
Yeah.
back,
So
and back and forth.
one of the key bacterium that people are using is Akkermansia municipida. And there is a tremendous body of work on this bacterium as being an anti-inflammatory bacterium, also a bacterium that synthesizes due to one of the proteins that sits on its surface, one of the peptides that induces the synthesis of GLP-1 and then show the direct effect on insulin sensitivity or insulin resistance. So yes, there is a lot of work, and that is also one of the key things that we have been doing. We don't just take a few bacteria, put them together, and then make claims around this. Everything that we do with these probiotics is based on the same rigorous science and the same experiments that we did when we were developing our life biotherapeutic products.
So do you think one day these GLP-1 drugs will be replaced by a probiotic?
I would say you will hopefully take these probiotics before you arrive to a point that there is a need to start taking these obesity drugs.
This episode of Halteres Presents is brought to you by the UC San Diego Extended Studies In Vitro Diagnostics Product Development course. Are you looking to take your biotech career to the next level? The UC San Diego Extended Studies In Vitro Diagnostics Product Development course is a unique, live online program designed for managers, entrepreneurs, investors, and scientists. This team-taught course by award-winning industry experts covers everything there is to know about the requirements for moving an IVD product from concept to regulatory approval and market launch. Explore real-world product development cases to help you plan for success by covering topics such as setting product requirements and specifications to meet customer needs, critical path management, resource planning, principles of assay development, instrumentation, role and composition of the product development team, risk analysis, and IVD clinical and regulatory issues such as compliance and complaint handling. Ready to get started? Enroll today and use our exclusive discount code to get a 10% discount on your enrollment. Use code HALTERES10 at checkout. That's HALTERES10 for 10% off the price of your UC San Diego Extended Studies In Vitro Diagnostics Product Development course. Just check the link in the show notes for this episode and use code HALTERES10 to enroll today. Accelerate your in vitro diagnostics career with the UC San Diego Extended Studies program. Your future in biotech starts here.
Your timing's probably very good here now too, Niels, because I was just reading this book, Living Medicine, and I just had no idea. It took more than 20 years for the FDA to even approve simple trials in humans. So, and they have a similar problem. They've got these groups of phage, and they change over time. They mutate over time. So, wow, if you had tried this 20 years ago, it would have been really tough.
Yeah, but I think overall, I mean, if I had to give a message for what we are trying to develop, I mean, the message to the market would be that the probiotic industry is built on sand. And we are offering the first solid foundation. And that's why we also say that these probiotics that we have, we saw that these were the foundational strains for a healthy gut microbiome, for the use of these LBPs.
Right.
So the probiotics that we are bringing to market are engineered for longevity. So they're designed for anti-aging, and I mentioned the functions that play a role there, not just GLP-1, but also GLP-2 induction, other functions. They provide sustained health benefits and not just temporary effects, because they're not transient bacteria, but they really get engrafted and established. And then you get the buildup of this healthy gut microbiome on top of the solid foundation that we are introducing. And we can do this because we make sure that our bacteria are alive when a person is taking them. So they are alive, they will colonize, they will persist, and then create this foundation. And then last but not least, it's really built on science, not on scent and buzzwords, because the previous generation of probiotics are really transient at best, they're misleading at worst, and I would say often a waste of money.
Yeah. It's certainly a much more controlled alteration of the gut microbiome than a
Yeah.
fecal transplant.
Yeah.
Much
And
more
that is
controlled.
another thing. I mean, fecal transplants, I think at the end, don't have a future for certain diseases. They form, in certain cases, a good intermediate situation, but at the end, you will have to come with defined consortia. And they can be more than just 3 or 4 strains. I think LBPs is a good example where you will replace fecal microbiome transplants.
Yeah, that makes sense.
Might these probiotics be considered GMOs? And if yes, how would you address some of the concerns that come from this community?
Rich, you mentioned an important point. So all of these bacteria are non-GMO. They are isolated from healthy individuals. All these strains are sequenced. We make sure that there are no hidden functions that could be bad for the human host, like virulence genes or transmissible antibiotic resistance systems, etc. So the bacteria in our probiotics, we make sure that they are GRAS certified, so generally regarded as safe. And that is really key. You cannot just take now bacteria from a human host and say, oh, these bacteria are probably beneficial. No, we make sure that we really understand these bacteria and do the necessary work to have them certified as GRAS.
It's a good answer.
I find it very difficult to talk to people about microbiome and convince them that this approach makes so much more sense than what they're doing today. This issue of you're considering functionality contributions from the bacteria and fungi, and I just don't understand why it's so hard to convey to people.
I always give this example. So let's say you would just look at bacteria being present or absent. It's the same like you would have let's say a grassland. And in one situation, you will see, hey, there is cattle grazing, let's say cows. Then you go to New Zealand, you have the grassland. It's slightly different, it's grassland. And there you have a lot of sheep grazing. Then you go to the tall grass areas in the United States, where you used to have the buffaloes grazing. Or you go to Africa, to the Serengeti, where you have the wildebeest grazing. So in a way, you have all healthy ecosystems. Some are man-engineered, others are natural. And you have grass or you have vegetation, and you have completely different organisms that are now roaming around on these grasslands. But in all cases, there is a healthy situation. I mean, I'm not going now into the discussion about whether agriculture is healthy. I'm just saying you have this situation, you have something, and you get organisms that interact with this ecosystem in a healthy way. So
Right.
that is really what it is. It's all about organisms having different functions, or having different organisms with similar functions. And that's why if you were just looking at the correlation between an organism and disease, it's very difficult to do that in certain cases. Of course, let's say you have Salmonella typhimurium in your intestines. Yeah, you will have a disease. If you have high levels of C. diff, you will have a disease. But in situations where the, let's say, the ecosystem is unhealthy, you have a lot of different players that can come in. But also in a healthy ecosystem, you have a lot of different players that can come in. And these players will, if you would just look at who is there, provide you a very different picture. But if you then look what these players are doing, you start to see, hey, there is a lot of common sense in what they are doing. And it's based on the functions that they need to thrive there and the outputs that they provide to this ecosystem. And that's what we are looking at.
It's a great analogy here because we really are talking about an ecosystem there, and we're talking about an ecosystem with the microorganisms within the human host, and we know what happens if you introduce a new species into an ecosystem that doesn't know how to deal with it, like a cane frog into Australia, it does remarkable damage.
Exactly. And so what you will see is either the microorganism or the organism is not getting established, then it's a failure. If it was to reintroduce a beneficial species, and you see that very often, people try to reintroduce something beneficial and it fails. Why is that? Because the other conditions are not there. And that's exactly what we are trying to avoid with our probiotics. We make sure that that we create the right ecological conditions, not by introducing one strain, but 3 or more strains that really work together to create the best opportunity for these bacteria to thrive again, to get engrafted. But as I also mentioned early on, not then to take over the ecosystem, but then become the foundation for these other beneficial species to create a healthy situation. And the best example from nature is the reintroduction of the wolf in Yellowstone. Once you started doing that, you start to get control of species that were having too much of an effect on the landscape. And the end is now a much healthier landscape, much larger diversity, etc.
Right. Similar thing happening now with the reintroduction of beavers in locations where they were wiped out.
Yep.
Very, very interesting.
Well, Niels, thank you very much. I'm sure our audience is going to very much enjoy listening to this podcast episode.
Thank you so much. And Mickey, thanks for inviting me.
Thanks so much. We really appreciate it, and we had a wonderful time talking to you. I think what you're doing is very important.
Halteres Presents is produced by Halteres Associates, a US-based bioscience consultancy that provides strategic and tactical services in the areas of diagnostics, medical devices, and life science research to clients of all sizes. The views, information, or opinions expressed during the episode are solely those of the individuals involved, and Halteres Associates is not responsible for any errors or omissions or for the results obtained from the use of this information. The information provided in this episode is for informational or educational purposes only and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. Halteres Associates would like to say thank you to this episode's guest or guests, and thank you for listening to this episode of Halteres Presents.